Welcome to Beyond the Call podcast, where we tell the stories of those people behind the jobs we rely on. We go into the good, the bad and the ugly, and we shine a light in what can be a dark place. Just a warning, the content can be graphic and distressing, so please use your discretion. Please like and subscribe on your podcast platform and our social media. And if you have feedback, I read every single one. Let's get on to this episode of Beyond the Call. Hi folks, welcome back here to another episode of Beyond the Call. I'm delighted that we've got another guest today. We're going from the big old US of A. So we've got Adam. Adam is a PICU nurse, Pediatric Intensive Care Unit nurse from America.
Welcome,
Adam.
Me on.
My pleasure, mate. I'm looking forward to having this conversation. So as we do, we start at the bottom. We start when you're a baby and we work our way up. So tell me about your childhood.
So I grew
Where
up
did
in
you grow
Minnesota.
up?
I don't know if you're familiar with where that is. Way up north near Canada, land of 10,000 lakes, Midwest of the U.S. It was a pretty good childhood. I'm middle child of three boys, and I was a good student. I was really into a lot of creative things as well. And so all throughout school, I kind of gravitated towards the arts, sort of as a way to differentiate myself from my older brother who was really into sports. So I was into piano, I was into theater, I was into visual art. And so when I was in high school, I was on the track to do like really hardcore science. I was doing all the like college level courses in high school with math and science. And, I got to the point where I was doing calculus and thinking about, okay, do I want to take like physics? I was like, no, I don't really have any interest in doing something with those fields professionally. And so I really got into Shakespeare, I really got into acting, and I actually went and I applied for a theater school. So my first degree is a Bachelor of Fine Arts in acting. I went to a conservatory program with the Guthrie Theater, which is one of the big regional theaters in the U.S., and did a 4-year conservatory training in classical theater. So that was my first profession. Yeah. So I did that for about 7 years professionally as an actor, mostly acting on stages. Moved out to the West Coast. Actually met my wife. She's my yoga teacher in Ashland, Oregon, working at a Shakespeare festival out there. And then we moved to the Bay Area outside of San Francisco and Oakland, California. And then eventually I decided acting was probably not going to be my final career path.
So theater was the main. Did you do any like
I did
TV
a little
or
bit of
anything
like
that,
commercials, did a little bit of like indie film stuff, but nothing really big from like a TV. I was in LA for like 6 months, decided that was not going to be my jam. I didn't not my thing. So, so I mean, I loved theater, but it was definitely not going to be the kind of career that was going to allow me to have, a house and a family and security. And it was a very high stress job too, in a lot of ways. I think they say that like actors have as much adrenaline as a fighter pilot in their system when they go on stage. So there's a lot of adrenaline, there's a lot of like stress, but also a lot of like excitement, and a lot of, challenge, and a lot of, high pressure environment, which kind of fit perfectly. I transitioned to nursing, and then my first job was in the emergency department.
So why nursing? How did you end up in the
it's
nursing
a great question.
field?
So I think what I needed to do when I was deciding what I wanted to be, because I was looking at maybe going into culinary arts or other, professions, but unfortunately we're very similar.
How old are we talking at the moment?
Gosh, when was I? Around age 29, 30, I think I decided that I needed to start looking into other kind of avenues, other paths that I might be interested in pursuing.
To grow up and get a real job.
That was kind of my parents were very much like, okay, when are you going to actually grow up and, exactly. So I think it was around that time I did a show with somebody who was going to school for nursing. And it was sort of going to be this like dual career path that they were going to try to do, where they would do like a travel nursing gig. Are you familiar with a travel nurse? Like they do like a short 3 to 6 month gig as a nurse, and then they go to the next hospital and they do another like 3 to 6 month gig.
Yeah, we call them sort of locum nurses, or there's a lot of relief nurses.
Exactly,
that type of
same
thing,
idea. And so the way theater works is you do like a show for 2, 3 months and you're off again, and you're on again for 2, 3 months and you're off again. So you're always constantly trying to fill that time in between. If you don't claim unemployment, you usually have some other kind of job that you pick up in between to make money and pay the bills and all that stuff. And so
It's the stereotype of most actors being coffee
yes,
people.
exactly. And so I think that, you know, for this individual, he was gonna do nursing in between as a travel thing for the months where he wasn't working as an actor. So I thought it was a really neat idea. I actually was really drawn to the idea, and, I was really good at s
Had you ever had any sort of drawing towards the healthcare thing before? Like, is it something that was there a seed planted back in the
Yeah, I mean,
day
I
kind
think
of thing?
initially when I was young and in high school, I was interested in like psychology and working with people and how to help people. And I think the reason that I really loved theater was it was all about connecting to individuals, right? It was that human connection piece that was the thing that really motivated me. And it's what I kind of drew a lot of my
Yeah,
satisfaction from that field was that idea of like being an actor, connecting to an audience, you know, connecting on a deeper level than just like, okay, this is not a transactional relationship. Like we're talking about like people's emotions, people's feelings. We're getting into like a soul level connection here. And that for me was what theater was about. And
yeah,
so nursing was almost the way I sort of saw it was this kind of similar in that vein, and that it was really involved relationships. It really involved connecting with human beings on a like, human soul level. Yes, we were doing healthcare. Yes, we were operating with like medicine and, things that were very sciency, but really what we were dealing with was human interaction. And so that was what sort of kind of was the kernel
yeah.
for me to be like, okay, I can do this. And so, um, obviously I went to school for acting. So I had none of the prereqs needed for a nursing background to go to schools.
So you're starting at
So
the
I basically
beginning.
had to like, there was a nursing program that started, it was like a year away. I had to get basically like almost 2 years of prerequisites, and I tried to mash them into 1 year. So I went on this journey of like teaching
Yeah,
myself, how to learn chemistry, how to do like organic chemistry, and a year's worth of chemistry I fit into like 2 months. And so what was interesting is because I was an
yeah,
actor and I was really good at memorizing information, I would like cram these books, these textbooks full of information, and then I would go and I'd sit in a test and I would just regurgitate information from my memory, and I would pass these tests. So I was basically passed out
yeah.
of like half of my prereqs in a matter of
Mm,
6 months. And then I went to a community
yeah.
college for
Did you actually understand what you were learning though, or you just spewing
no,
it
I actually was
verbatim?
I was it was something was like turning on. It was like a part of my brain I hadn't been using. It just sort of lit back up. It was just like being in high school again. It was like,
Yeah,
oh,
cool.
this part of my brain is also really capable of not just understanding this information, but like synthesizing it, using it, and applying it. Um, and that was really exciting again. It was like a
Yeah,
part of me was like reclaimed almost. And so that process
yeah,
happened over a period of basically I said like 13 months. I went to school, community college to do patho, anatomy, and microbiology, like the three big ones that everyone kind of that's sort of like where you cut your teeth and you decide you can do this or you can't.
yeah.
And so
It's learning
yeah,
another
basically,
language.
and so I did that all in
Yeah,
one semester, those 3 classes. It was just that was all I did. And it was thrilling. I loved it. I was like, pathophys, something about it, it was just like my brain I told my wife at the time, I was like, "Honey, my brain's on fire." Like, literally, like, something is just like turning on, and, it was really exciting. And so, yeah, I finished the rest of the courses work that I had to do. I applied to school. I got in. It was a 1-year accelerated BSN program. So in 12 months, I came out with my BSN in nursing. And so I
okay.
started working in a pediatric. So initially, I wanted to do pediatric ICU. I did like my last sort of kind of clinical rotation in an ICU in Oakland, at a pediatric hospital, and I wanted to do PICU. That was like all I wanted to do.
Did you always want to do pediatrics throughout your training, or was that just something that sort of narrowed down when you
Yeah,
got
this is gonna
got
sound
through it?
kinda bad, and I think people who are in pediatrics will understand this, and people who are I don't know, maybe not, but, um, something happened during my training where I made a very clear delineation between people who had things that happened to them and people who made choices in their life that led to their illness, and there was a significant
Yes.
lack of empathy that I felt for people who put themselves in the situations. So dealing with like chronic health issues
Hmm.
and stuff where they were lifestyle decisions that were made that landed them in a state of disease. Obviously, it's more complicated than that, and there's a
Yes.
lot of other things that go into it. And you can't just boil it down to this black and white like they did this to themselves. But when I was in school, there was a very clear understanding that I would have less empathy and less ability to care for people who I felt heavily contributed to their disease process versus pediatrics, where a lot of things that
Yep.
happen in pediatrics is either inherited or something traumatic happens, right? There's not a lot of choice in that. And also kids are just way more resilient,
Yeah.
or way more resilient than adults. They don't know how to stop fighting, right? Like their will, their spirit, it
Yeah.
just keeps going no matter what.
Yeah. The thing I found when you're treating kids, if they're not hurt, they don't carry on with it. If an adult gets an ouchie, they're still sulking
Yeah.
hours later. Yeah, and that's why kids when they're crook, if you give them paracetamol and they feel
Yeah.
better, they're playing. They
Yeah.
might still be crook, but because they're not feeling crook and they're not sulking about it, they get on with
Yeah.
life. They
There's a
love it.
lot more lightness, a lot more happiness. There's a lot more joy in pediatrics, and I think the people who gravitate into pediatrics also have a very similar kind of playfulness, or at least they're like their inner child's a little bit more alive. And so there's a
Yeah. And yet people think it's the exact opposite. They think PICU or anything to do with pediatrics is sad and tragic. And don't get me wrong, there is
sure,
sad and tragedy, but that's the only thing they
yes,
associate with it as
yeah,
an
and I think
outsider.
there is a lot more heaviness when a child dies than when, an 80-year-old passes away, right? Like, there's a big difference between someone who's 7 years old, who's fighting an illness that they had no control over, who passes away tragically, versus someone who's, you know, in their 70s, 80s, 90s, who, had a good life, lived, a full life,
Yeah.
has something that they're leaving behind, some legacy, you can rationalize these things and you can come up with reasons why it's okay. It's a lot harder to do that in pediatrics.
Yes. Yeah. Absolutely agree. And yeah, I think it does. It really does draw certain people in. I think it's the same as
Yeah,
palliative care, though. That's a
yeah,
certain type of person
absolutely.
as well. Oncology is a certain type of, there are such broad requirements of specific nursing things that
Yeah.
everyone can find their little bit. And health nursing is a whole different beast again,
Absolutely.
which we'll get
Absolutely.
into later. You're gonna
Yeah.
slay
Oh
that
my god.
beast. So okay, so you end up so you did a placement
Yeah, and
for
I love the
pediatrics
ICU. Yeah,
during
I felt like
your
that was where
college.
needed to
Yeah.
be. I felt I belonged there, and while I was taking care of
What's a case you
yeah.
remember? What's something during your placement? What's something that sticks
Yeah,
in
so
your
there was
head?
a patient that I was taking care of that was an oncology patient that was in the ICU that had like literally no immune system. Was like in a positive pressure room so that no one, like no bugs would get in there. And it was a really difficult case. The kid was in so much pain. They were basically near the end of their life. The family was fighting with the providers and all the nurses and firing everybody that was taking care of their child because they didn't see things the way they wanted them to see it. And it was a very difficult situation ethically. It was very complex. They didn't want their child to
Yeah.
receive pain medications because they associated with her being sleepy or, like, dissociated from what was happening, and they wanted her to
Yeah.
be alive. They wanted her to have light in her eyes.
They wanted quality,
Well,
quality.
they
Yeah.
wanted to have interaction with her, right? They wanted to feel like she was still with them,
Yeah.
but she was suffering terribly, and she
Yeah.
was in tons of pain, and they were refusing to let us treat her pain. And the child just, I mean, she was at the end
Yeah.
of her life and she just needed to be comfortable, unfortunately. And they were
Yes.
holding out for these experimental, at the time, there was the cytotoxic T cells that everyone like, they engineer to fight cancer, like CTLs that are like now commonplace for therapy at the time, was like experimental. It was only like a couple trials that were being done across the country, and they were trying to get into one of the clinical trials for it, and she was just too sick. She was septic. She had like every comorbidity, every complication. Like
Yeah.
she never made it. And so I had you spend a lot of my time as a student in my last rotation taking care of this young child and seeing how complicated it was, seeing how much the patient, but also the family was in pain and how much it was affecting the care team. And there was something about the complexity, but also the depth of humanity. There was something really beautiful and tragic, but also it was a space I was feeling called into. Something
Yeah.
about my kind of journey, I think, with medicine is for me to go into those spaces that are really hard and really complicated and to learn these lessons in them.
Yeah. Did you have a child at that age? I'll let everyone know you do
Yeah.
have a child now, but did you have a
No, this
child at
is
this point?
before so right before we had our son, we adopted our son, at birth. This is about a year before we got our child. So
Okay.
yeah, we were
Okay.
single in the Bay Area, having a good life, and I was in school and yeah,
The reason I'm asking that is just is obviously, and this is a question we'll get into later, but obviously having your own child
yes,
changes things. So I was just wondering, did you go in it with a child, or have you got the child later on? So we'll
yeah,
we'll talk about that later on. That case sounds as an observer like a fascinating, as you said, tragic, horrible case, but the type of case that is perfect for somebody
yeah,
doing their student
yeah, oh, yeah,
placement because you get to discuss every aspect of it and you learn more than any textbook could
yeah,
ever show you. As you said, the
yeah, and
human
that was
side
stuff
of
that we weren't
things.
learning in school. It was all the stuff that I
Yeah.
realized I was going to learn during my career that I'd only learn from doing it. It's not something that someone can explain to you. And so
Yes.
I came out of the rotation and all of my teachers were terrified that it was going to turn me off from pediatrics. It was going to turn me off from ICU. They were all worried about how I was doing emotionally. They thought maybe this was going to be too much for me. And I actually did the opposite. It really inspired me to pursue pediatrics and to pursue working in these spaces. So when I went for my first job, there were no unfortunately, that hospital had hired someone from the year before me, and there were no placements for a new grad nurse in the Bay Area in ICU anywhere. And so I started applying outside of the PICU, thinking that maybe emergency medicine would be interesting. Also very high acuity, very challenging, a lot of adrenaline, the things that I was looking for at the time, apparently. And so, I actually got, a job offer in Alabama, long story. Um, but we decided we wanted to be near one set of our parents because we were in the process of our adoption. And so at any point in time, we were gonna
Yeah.
get a phone call and have a newborn baby. And so my wife was traveling for work at the time, and I was just starting my career in nursing. And so we were either gonna go to Minnesota or Alabama, and we didn't want to go to Minnesota because it's too cold. So we ended up in Alabama, which was a very interesting cultural experience. I don't know how much you know about the US
Yeah.
and the South and all the different coasts. And
And not a lot about the intricacies and the different. We have our states over here, but they're nowhere near the difference that
yeah, we
you
went
guys
from
have
basically the
over there.
most liberal area in the whole United States, the San Francisco Bay Area, to the one of the most conservative areas in all of the United States. So big culture shock that happened.
Right.
I learned a
Yep.
lot in that first year as a new grad nurse in the ED, but I did not enjoy my time in Birmingham, Alabama, from a personal and other sort of situation. Is also very eye opening,
Yeah.
but not the kind of experience I
Yeah.
wanted to continue to have.
And see, an ED nurse over there is very different to an ED nurse over here. We don't have the
Yeah,
gun violence. We don't have what's included in healthcare and insurances. We don't need medical insurance. We have private health insurance where
yeah,
you can go to private hospitals, but if you're shot, you're not getting
yeah,
a bill. There's nothing over here. It's all covered by taxes and
yeah.
government and stuff like that. So it's a very different experience. Did you what was the main drug of play when you were working in the ED? What was the main illicit
Um,
drug?
in terms of ingestion,
Yes, yeah, like, now it's
yeah,
fentanyl. What was it back then?
bath salts was a big one. A lot of teenagers inhaling in bath salts. A lot of synthetic marijuana. Um, Trying to
Yeah,
think what else the big ones were. Not a whole lot of opioids at the time. There was some meth, but not a ton. trying to think back. It wasn't, it was
Okay.
so I worked at a level 1 trauma center. I don't know if you guys have the same distinctions of, like, levels of trauma centers in Australia. They have, like, different distinctions.
To some degree, we have
Okay,
main trauma. We do have tertiary
gotcha.
level hospitals that do the
Yeah,
tertiary training and stuff like that. So I guess we'd call them
okay,
tertiary hospitals. But then within the state, we have specific spinal
gotcha.
hospitals, the burns units, things like that, that
Okay,
are more dedicated to those. I mean, we're a bit different. Our states are
yeah,
huge.
yeah,
I can travel. So if I travel 15 hours south, I'm still in
okay,
the same
yeah,
state.
gotcha. So, yeah, and basically the way it works is that not every state has like, large regional pediatric hospital in them. And so in Alabama, there was not a whole lot nearby in terms of, like, level 1 trauma centers, and so that distinction just means that, like, anything that was significant in terms of burns, traumatic injury, like motor vehicle accidents, gun violence, anything like that, came to a level 1 trauma center because they had certain specialties that
Yeah.
could deal with whatever came in the door.
Yeah.
And so basically, we were in a large
Yeah.
urban area, a lot of violence, a lot of motor vehicle accidents, a lot of child abuse, unfortunately, and we got it all from the scene. So basically, as a new grad
Yeah.
nurse in the ED in Alabama, I was in literally every single trauma or resuscitation that took place as part of my learning, and I learned a ton. I learned how to be a trauma
Yeah.
nurse in Alabama, and I loved.
Did you ever go out in an
No, we never
ambulance?
did. We never did, like, ride-alongs. No, sometimes the physicians would do that, but the
Yeah.
nurses, no, we were in the hospital waiting for them to arrive. So we would get all kinds of crazy
Yeah,
stuff.
it's something I would love to see
Yeah.
that happen more. I remember doing training back when I trained. It was before we did it through uni. We spent time
Okay.
in maternity and we spent time in theatre. But I remember the anaesthetist when they're teaching you to do, with your airways and things like that, say, you make sure you move the light over to here. Make sure you put another pillow under their head. And we're like, our pillow might be our boot. We might be upside down. We don't have a bed that
Yep.
goes up and down and all that. You
Yep.
guys need to come out and, if you're going to teach us, which I
Yeah.
fully respect your skills, you've also got to see
Oh, I
what
have
we do.
tremendous respect for everyone who works on the scene. Paramedics, firefighters, EMS,
Yeah,
absolutely. You guys are, yeah, it's a
absolutely.
totally different ballgame. Absolutely.
Yeah. Same. I loved doing what I did, but I don't know if I could stay with patients long enough to become a nurse.
Well,
It's the good
what's
thing we could do
interesting
is
is
hand
that
them
in the
off.
ED, right, this is one of the things I actually came to realize was part of my resiliency is that I would resuscitate a patient, I would stabilize them, and then I would ship them off to the ICU or wherever they would go. I didn't actually have to stay with them for 12 hours. And so in some ways, there was a
Yeah.
protective aspect in that where I almost didn't allow myself to get too close to patients because I wasn't interacting with them day after day after day after day,
Yeah.
week after week after week. And that was different.
Yeah. There was no
Yeah,
personal relationship or professional
right.
relationship with that
Exactly.
patient.
And so,
Yeah.
seeing all these
Yeah.
horrific things from a traumatic standpoint, right? Like violence and everything else that we dealt with, there was something about it that was tolerable because it was brief, right? We would have these like brief flashes of intensity and then we were done.
Yes.
So it's very similar to,
Yeah.
EMS or firefighters, first responders, right? Like this flash of intensity, this horrific violence that you're faced with, and then you pass it along. So very similar.
Yeah. And people used to ask, how do you describe the job? And my most common response was 95% boredom,
Yeah,
5% panic.
absolutely. Right. And so there's something I think actually
A lot of it was so routine, and when it's not routine, it's holy shit,
right, but
what is
there's something
happening?
I think protective about the fact that you have so much adrenaline going through your system that you almost respond on instinct. You're not thinking about the consequences of what's happening in front of you. You're not worried about what's going to happen 6 hours, 12 hours, days, weeks, months from here, right? Like your focus is very immediate. You're
Yep.
very in the present. And so there's something
Yes.
about that you are operating out of a place more of instinct rather than from a place of emotion or a place of contemplation or reflection. There's a lot. It's a very different kind of, I think,
Yeah.
interaction that you're having. There's a very different space that you occupy in your body and in your mind when you're in those situations versus the ICU where I am now.
Absolutely. And, yeah. And the other thing with first responders and the ED is you can literally be
Yeah.
saying goodbye to an 80-year-old 1 minute and delivering a
Yes.
baby the next.
Yeah.
So you've got the full gamut of this full
Yes.
spectrum of life that comes through you, and that can
Yeah.
be in one day. It really can vary. Did you ever experience any violence
Oh,
yourself when
yeah.
you were
So
in
we
the ED
also in the ED, we
towards
also
you?
have to take care of, psych patients. So part of our job
Yep.
as a ED nurse is that you have to sub in for basically, if there's not enough psych nurses, you had to kind of step in as a psych nurse, or if there was a patient that was escalating, you were part of the team to help de-escalate. So you learned all these techniques around like how to do holds that were, safe for you, for the patient. So yeah, we got swung at a lot. We got kicked at a lot. We got cursed at, spit at, a lot of stuff like that happens. And this is pediatrics, right? So you're dealing with children, you're dealing
Yep.
with the parents of the children. And I mean, you're a parent, I'm a parent. If someone messes with my kid, it's probably one of the worst things that someone could do, right? Like I am going to respond and react from
Yep.
a very like emotional and primitive state of mind, not from. I'm not going to be
100%.
thinking, oh, this poor nurse who has to
100%.
deal with me. I'm going to probably lash out with a little bit less awareness around how I'm acting if it's my child
Yeah,
that's in danger or someone's hurting my child. Yeah. And so a lot of that I think is
absolutely.
unique to pediatrics as well. Not that it doesn't happen in adults with, family members and other people who are involved, but in peds, it's one of those things that I think isn't maybe talked about as much.
Yep. Yeah, cool. I was gonna skip ahead. So I'm guessing that when you're dealing with peds, you're treating the patients just as much as you're treating those sick children.
The parents and this child, yeah, absolutely. We call it family
Yeah.
centered care because really you're like, yes, you're applying medicine to the child, but then you're also building a therapeutic rapport with the parents. Really, the success of
Okay.
how things go very much is built upon those relationships you have with the parents themselves or caregivers, whoever's involved.
Yeah.
Yeah.
And that's even the case in the ED or first responders. If you go to a kid who's got bone sticking out of their arm or leg and parents are panicking, the first thing you do is you
Yes.
calm the parents down because they feed the child. And then when you got control, you're obviously still treating the child at the same time, but you're putting a lot of effort into controlling those
Yeah.
emotions of the parents. And then the whole thing de-escalates so quickly. And I'm not talking about aggression. I'm just
Yeah.
talking about emotion. No one wants to see their kid with bone sticking out of
No.
their body. So if you can take care of their pain, but also take
Yeah.
care of their panic, then
Absolutely.
you're
I mean,
winning.
I always have to think that this must be one of the worst days of the life for the parent or caregiver watching their child suffer, watching them in pain, watching them with some horrible injury, right? Like that first encounter that they have
Yeah.
with a care team, with a doctor, with a nurse, right? They're terrified. They're completely out of their mind, right? And
Oh yeah.
most of the stuff that you say to them, they're not even going to remember. They probably aren't comprehending what maybe 10 or 20% of what you're actually saying. Like they're in shock. They're completely in shock. And
Yep.
so how you handle them, yeah,
I remember I went to a child once who had fallen out of their change table was right
yeah,
next to a window, and they'd fallen out and fallen maybe two
yep,
meters onto the ground out of this window. Luckily it was on a first like a on a just a slightly elevated house. The parent was a
mhm,
was an ED doctor,
of
but
course.
lost their shit. And so, and people think that, their training will kick in.
No,
When it's your kid,
no.
nope.
You just
Training goes out the window and you are, you
oh,
are,
yeah,
you are just
yep,
tribal. You're primal. You
yeah,
are, yeah. And the worst thing they can be
oh,
is a
yeah.
physician at that
Well, because
time.
then you know everything can go wrong and you're worried about all the what ifs and yeah, oh, yeah.
Yeah.
That's some of the
Yeah.
hardest parents to deal with are people who are in the medical field.
Hell yeah. But at the same time,
Yeah,
the toughest kids you'll ever see are
yeah.
the kids of people in the medical field, because if there isn't blood
Yep.
spurting or bone
Yep.
sticking out,
Yep.
get over it.
Yeah, my little boy, he broke his
If
arm 2 years ago or yeah, 2 years ago. And the nurse first called my wife, she didn't answer because she was busy or her phone was off or whatever. And then they called me and I'm like, "Thank God they called me." And I was like, And so I showed up first, and my wife's like, "What happened? What happened? What happened?" I was like, "Honey, Jack broke his arm. It's okay. I'm at the nurse's office. We put in a splint. We're gonna go to the urgent care and get an X-ray. Everything's okay." Because the minute I showed up, Jack, he was freaking out, crying, really upset. The minute I showed up, I was like, "It's okay, honey." Immediately, he calmed down. And that's the thing about, I think, peds, I think is really
Yep,
interesting is that they take their cue off the parent. So if the parent's freaking out, the kid's freaking out. So you calm the parent, you calm the child, everyone's
absolutely.
good. So, I mean, I wish
Yep,
I made a joke that we would hand
absolutely.
out, like, Ativan Tic Tacs in the waiting room in the ED. And so the parents could just mellow
Before
out.
they
Yeah.
come through.
Just be like,
Absolutely, but it's so true. When we arrive to a scene, or they come first through that door, yeah, if you can keep them
yeah,
calm, you've won 90%
yeah,
of your battle with the
absolutely.
patient. It's my number one goal
Yeah,
is make them laugh. If you can get a giggle out of somebody at their worst moment, you've won most of the battle of getting them on
absolutely.
side. The amount of times I went to old people that have had a fall and the first thing you'd say to them, "Did you have too much scotch for breakfast?" And the you'd often have their adult daughters or sons there.
Uh-huh.
They'd have a giggle at that, and then that would create banter and conversation. Automatically,
Yeah.
that pain is decreased from a 10 down. I'm not saying how much, that varies from person to person, but if you can build that rapport, if you can get people mellow, like you said,
Yeah.
they eat off each
Yeah.
other's tension,
I mean,
feed
humor, I
off it
think, is
big
a
time.
huge part of our jobs. I think it's one of the things that keeps us sane and healthy is that we have a lot of dark humor. I'm sure that it'll come out as we continue to talk.
Yeah,
But anyone who's been in these sort of fields, they develop these sense of humor that is not only protective for themselves and for their healthcare workers, but like also for the parents, the families. Like you've got to laugh in these situations, otherwise you're just going to cry and not stop. So I think it's a really important thing for
absolutely.
everyone, right? Like, it's a good thing to have a laugh at life. You can't take it all too seriously.
Yeah. Can I ask what your
Yeah,
wife
so
does
she
for work?
actually was trained as a social worker, um, l left that field,
Okay.
went over to Southeast Asia for a couple of years. She was also a yoga teacher, came back, was teaching yoga, opened a store selling all this yoga stuff, um, changed careers a couple times, did sales, and then kind of, took a back seat and it mostly just sort of was, primary parent the last 10 years, and now is going back into social work
Yeah.
to do
Yeah.
therapy with people. So, she's kinda come full circle, which is really
I like
I mean, she
healthcare
did
type of
hospice care,
fields. So yeah.
dialysis.
Yeah.
She's a lot of stuff that I talk about, she has some understanding of or was at least exposed to some of it. So that's been helpful.
Yeah, absolutely. The dark humor thing is a huge thing, and it's something that I'm actually really excited. I've got a guy coming up on the podcast in a couple of weeks, and his business. He was a stand up comedian who then studied his
Yeah,
masters of suicidology because he realised how much that laughter and depression and
yeah,
suicidology is linked. And it is, but we develop
yeah,
that dark humor. We don't often. We often it's the same type of people that go into specific kind of
mhm,
genres of healthcare, but we develop the dark
yeah,
humor as we go as a coping mechanism from
yeah,
feeding from other people. And I think what people need to know is it is
yeah.
never meant to offend
Oh, yeah.
any. It's not meant to anyone. I don't want anyone hearing our conversation if we're having a
Yeah.
true off the wall, no dark humor thing. It's the most offensive
No, when
thing
I was
out
a
there.
student, I remember hearing jokes that the nurses were making and being shocked. Like, I thought I had a pretty dark sense of humor
Yeah.
in acting because you also I mean, there's a lot of inappropriateness in theater as well. But I was shocked. I was like, "Oh my god, how can they be making jokes about this?" But then, yes, it is a coping mechanism, and there's actually a lot of literature on this as well. This is a
Yeah.
very well-described phenomenon in
Absolutely.
healthcare, and I think as you're in it, you kinda realize, okay, you have to, otherwise you crumble.
Yeah. Yeah. And I like what you said before, or I'm picking up on what you said before when you said about if something happens, you'll cry and you won't
Yeah.
stop. The crying bit is, I find, a really interesting thing. There's a big
Mm,
stigma in healthcare. I don't know if it's changing, but you don't
I
cry
do.
in front of patients. I was a bloody crybaby in front of patients. But
Yeah.
if things were sad, if I Look, if a patient died in front of me and there was no one there, it's sad. I give them and the
Yeah.
body the respect it deserves, but they are a
Yeah.
deceased person now. Dealing with people left behind, that's the bit where I cannot
Yeah.
not have tears in my eyes. How do you deal with your emotions when they're raw? Like, um, ultimately, have you cried in front of a
Yeah. So,
patient or
yeah,
their
I
family?
definitely have. I think there's a part of it where, especially, so now I work in the ICU, which we'll get to eventually, but you do develop deeper relationships with families, with patients. Um, and there's a part of that process, especially when there's a loss of life, um, that that I think families want to see that you're also human, right? That they want to know that you also are feeling what they're feeling, and there's something about that empathy about, and not that it happened to me, not that it was my child, not that it was my loss, but there's a certain part of empathizing with the situation that I think is human, that is natural, and that I think is healthy. And I think if you, not obviously
Yeah,
to the point where you're crying so much that they're taking care of you, right? You're still the provider or the nurse taking care of the family and the patient, but there's a certain amount of emotion that I think is natural, healthy, and I think is there should be space for. But I know a lot of people feel that way.
do you think it? Do you think that's trained? Do you think they allow you or talk about that
No,
enough during
no,
training of being a
no. I
nurse?
think the training is to
No.
not show emotion, to not feel. And I think in an ED, as the ED nurse that I was, I never did in the ED, right? Like it was not okay. It was not part of the culture. It was like you're tough, like you could handle it. Um, we can get into that in a minute, but
Yeah.
yeah,
Yeah, I remember I was working out in a small town, 600 kilometers from anywhere kind of thing. And I took in a guy who'd had a hemorrhagic stroke and he was clearly not going to make a flight. Like it wasn't worth
yeah,
sending him on a flight. So the doctors out there, they are the emergency hospital doctors. They're the general practitioners. They are
mhm,
the jack of all trades. And it was the first time where I remember I had tears welling up in my eyes as we were there I stayed with him and we
mhm,
both explained to his loved one what was happening. This man is dying. There's nothing we can throw him on a flight and get him to Rockhampton, for example, one of the major centres, but he's just going to die
yeah,
alone. So as we were saying that, my emotions were building and the tears were welling, and I was embarrassed for myself because you don't do that in healthcare. And when I looked at the doctor and he had tears in his eyes, it was the
mm,
biggest relief I have felt in a long time because I had never cried in front of someone in
yeah.
healthcare before. And it it was embarrassing to do, but that gave me permission to allow it. And from that moment on, I just let my emotions be emotions. And as you said, you don't want to get to the stage where they're looking after you, but there's nothing wrong with them seeing that you feel
Yeah,
their pain.
absolutely. I mean, I have a story about kind of how I changed my approach to this specific issue about how much letting myself feel what was going on with my patients. Because I think my
Yeah.
strategy around this was just to build my armor as thick as possible, to have my walls as high as possible, um, and to really not let people in. And I did that. Oh,
Yeah.
totally.
Be a
And I did that
robot.
for probably 5 years, um, until I had a situation with a patient that completely just destroyed me. And I mean, I could tell the story. I don't know
Yeah.
how much you want. We can go into it or not. It doesn't matter.
Yeah.
Um,
Go for it. Go for it. Yeah. Please
so
do.
we moved to Colorado after my year in Alabama, and I worked at the Children's Hospital here. And so I was there, also level one trauma center. Turns out Colorado has more child abuse than Alabama, which is sort of shocking. And so we have a lot of stuff like that, and then we also have a lot of SIDS situations. So um, always
Yeah.
that like
Yeah.
4 a.m. lights and sirens blaring coming in. The child's been down for probably hours, but you still have to do resuscitation, you still have to do
Yeah.
CPR, and a lot of times, and this is probably something that people don't know, unless they do healthcare, is that we will continue CPR until the family arrives. And so we're often doing CPR on a baby who's like cold, stiff, obviously dead. And sometimes
Yes.
that goes on for like 45 minutes, an hour. Like it's one of the hardest things
Yeah.
that we do
Yeah.
as healthcare workers. And we do it for the families because, studies show that if the family sees you doing everything you can possibly do to save their child, it makes them able to process the loss and the trauma of losing their child a lot easier. And so there's this thing that we
Yeah.
do for the family that basically destroys us, but that's what we're doing. It's coming
Yeah.
from our understanding of what's best for the family and for the parents. Um,
Yes.
it's one of the saddest
Yeah.
things that we have to do in the ED. And so this baby came in who was likely SIDS. Um, and we did
Yeah.
this resuscitation on this child for like 45 minutes, and they were blue, like purple, stiff,
Yeah.
cold. Um, and the mom and the dad show up, and as soon as they show up, we do like one more round, and then we call it. This family
Yeah.
was not English speaking. I'm not sure what language they spoke. It may have been Vietnamese, it may have been some other kind of dialect that we couldn't find a translator for, but it basically couldn't really communicate with language what had occurred. Um, and the mom picked up this baby that was cold and long dead and started rubbing the cheeks to bring blood back into the baby's cheeks, to back into the face, to like bring it back to life. Um,
Yeah.
and because any SIDS case that comes in automatically is an autopsy case, it has to be ruled out for any, abuse. I knew this, and I was the charge nurse, and I was also in the trauma and doing resuscitation, and I had to convince the mom to give me her child, like out of her arms, without
Without
words,
words.
basically begging her to give me her baby that she was in the process of grieving because I was afraid she was going to do something that
Yeah.
was going to look like maybe she had hit the baby or hurt the baby or rubbed skin off the baby's face.
Yeah.
I didn't want her to get in trouble.
You were doing something that actually
Yeah,
protected her.
but she didn't know that, and and then I couldn't use words to
Yeah.
tell her this, and basically just had to beg her to give me her dead baby from her arms. And this took like half an hour, honestly. And it was me and the social worker and the mom and the only people in the room. Everyone else was just giving us privacy. The cops are outside the room. Everyone was waiting to like get involved. But until she handed over her child, no one was going to do anything. So the minute the mom gave me her baby and she walked outside the room, and she was just like wailing, that like gut wrenching, like wail from like the bottom of your
Oh, yeah.
soul, like loss. I've heard that so many times.
I was going to say, you only know
Yeah.
it if you've heard
It's
it.
like keening is what I it's like
Nothing
keening, right?
prepares you
It's like
for it.
that Irish wail. It's that like yeah, it literally just like
Yeah.
pierces your soul. Um, and that's what was going
Yeah.
on. And so I was just keeping it together, totally like got it together. The minute I got the baby, I just swallowed the baby up, put it on the bed, and I literally like
When you say you were keeping it together, were you overriding or were you
bottling it.
bottling it? Or it
100%
wasn't there to
bottling
co
it.
okay, so
And
it
the
wanted to
minute
come
and the
out?
minute everyone
Yeah,
left the room
okay.
and it was just me and the social worker, I literally collapsed to the floor and I, like, lost it. And I cried those tears that the crying that, like, never stops. And they literally had to, like, pick me up off the
Yep.
ground, brought me into the unit. There was another person there who was, like, a manager who just gave me this hug and, like, wouldn't let go, and I just wept in her arms for, like, 10 minutes. And then I was charge nurse. I still
Yep.
had to run the unit. Like, I still had, 10 hours of
Sure.
my shift. It was the beginning of
Yep.
my shift, and I'm like and of course, anyone else would have just gone home, right? If this was any other type of work, we would have just gone home and been like, "Okay, we're done." No, I just took a lap around the hospital.
It's
I got a drink
yeah,
of water, ate a snack, and I finished the 10 hours left of my shift like nothing had happened, right? Like,
yeah.
this is the kind of stuff that we do.
It's you can
Oh,
compartmentalize
absolutely.
it. You can just, yeah,
But I
move
think what
along.
I
Yeah.
realized is I'd put that armor up for so long and that strategy was not effective anymore. It wasn't just this one baby, this one
Yeah.
child that I was crying over, right? Like I was literally crying
No.
over all those losses, all those traumas, everything that had occurred up until that point that I had just kept in for
Yeah.
so long. and it was like finally the dam broke.
Yeah.
The
You
dam
felt the
just broke,
feels.
and all of a sudden it just came pouring
Yeah.
in.
Did you feel better for it afterwards?
I mean, yeah.
I know, you know what I mean by
It was
that.
that one of those cathartic cries, right? Where like you just have to get it out and then
Yes.
you feel better. But what I realized was there was a fragility, there was a vulnerability there that I wasn't accepting or I hadn't been honest with
Yep.
myself about. And then I knew that I needed to find another way
Yep.
of dealing with this career, with this job, with the things that happen to us in this field because the strategy of having armor
Yep.
and not feeling wasn't working, obviously. Um, and so I needed to find a
Yep.
different way of dealing with it.
Um, in regards to bottling it and not crying, do you think there's a difference on how male nurses and female nurses deal with that? Because and I'm not trying to open a can of worms here, but women in society is acceptable to cry. You're brought up from that as a child. As a man,
Mhm.
it's changing, thank God, but it hasn't been. And so, have you witnessed differences between males and females in the regards to the emotional
Yeah, and I
response
think
or
yeah,
outwards
I think that
emotional
it's
response?
very cultural. I think in pediatrics is a
Yeah,
little bit different. There's a little bit more sensitivity. There's a little bit more awareness around that stuff, and I think it's more acceptable. It's not looked down on. There isn't that same kind of stigma to it.
yeah,
Um, but yes, from a
yeah,
cultural standpoint, right? Like men don't express feelings as outwardly as females might.
yes,
And that is, I think, still a norm of our society, and I still is something that's still at play.
yeah.
But I don't think it's specific to healthcare.
Yeah, I think it's changing. I
Yeah,
think it's changing. I agree. I don't think it's specific to healthcare. I think society-wise, it is definitely changing, and I think
yeah,
that's a bloody good thing. We have to be able to show our emotions because then you don't bottle it up and you don't
yeah,
become a robot. So from that, so did you notice after that happened that you were able to express emotions easier moving
yeah.
forward? The case kind of thing, if you know what I mean, as the
Yeah,
case
so I think
required?
around that same time so at this point, I was in school for my nurse practitioner license, um, and so I was in the beginning of transferring from being a nurse to being a provider. Do you have NPs in Australia?
Yep. Did
Yeah.
we do, but I was gonna say, can you explain to people that don't know what the
Yeah,
difference
so,
is?
basically, as an advanced practice provider and an advanced practice nurse, you basically get prescriptive authority like a physician, and you get more autonomy, so you get to make clinical decisions. You're the one writing orders for the nurses to complete, and so you are basically operating very much like a physician does. Um, so
Yep, yep, and
yeah,
we have it, and that's the
yeah.
same that
So I
happens
was in
here
the
as well.
process of
Yep,
transitioning into my role as an NP, um, and I think this situation kind of was perfectly timed with my transition into the ICU. Because what I had realized was that I had to allow myself to feel what was happening with my patients, what was happening with the parents, um, and not just hold it in. And so I was allowing myself to feel. So you're asking about, do you cry in front of patients? This is sort of the beginning of the journey of like, well, I'm going to let myself feel. I'm going to let myself express what I'm feeling. I'm not going to bottle it up. I'm going
yep,
to let people see how I'm feeling about the situation within, the appropriate
yep,
limits, right? And I'm not gonna like break down and have them taking care of me and making sure that I'm okay. But that I'm
yep,
really gonna be
yeah,
more cognizant of letting things actually like move through me and let them affect me. So
yep. And I think, as you said, and I think you alluded to earlier, that makes a huge difference to how they see you. You are not just a robot. You are not just a clinical
yeah,
person. You're a human being as well,
yeah,
because you're with them on this
yeah,
horrible journey.
absolutely.
From somebody who hasn't worked in a PICU or anything like that, what is the difference between a role? I'm imagining a PICU is you've got lots of staff. You've got, the nurse and doctor and nurse ratio to staff is
Yeah.
obviously quite high. What is the difference, or where does a nurse practitioner fit
Yeah,
within
so I
that?
think nurse practitioners function differently depending on what hospital, what unit. In our ICU, our advanced practice providers, or our PAs or MPs, um, they function. autonomously. So they work under an attending physician who has like kind of ultimate decision making and kind of ultimate supervision of the patient, because it is an ICU. But
Yep.
a lot of the choices, a lot of the decisions, a lot of the like minute to minute things that are happening are m- largely decided upon by the APP, especially as you get more experience and you get more facile with your job. There's a lot more. Your leash is a lot longer.
Yeah. You earn their respect and they give
Yeah.
you a lot more. Yeah. So, so is it really a matter of that way you can have, from an economic point of view, you can have more patients, more nurses, less
Yeah.
doctors, because the nurse practitioner is sort of filling
Yeah,
that gap.
basically. So, I mean, there's
Yep.
probably what 5 or 6 APPs on and 3 attendings on, and then, of course, there's a resident team 'cause it's a
Yep.
learning hospital and all that stuff, but, there's sort of this division of
Yep.
labor where the APP is sort of the frontline provider, so a lot of the face-to-face, a lot of those, conversations that are happening are with the APP, with me, like an MP,
Yep.
um and the physician's also maybe part of them too, especially if it's like end of life or really big discussions that are occurring. But a lot of times it's me having those conversations one on one with the family member about what's happening, especially if things are not going well. Those minute to minute updates about how things are happening or where they're progressing. And the attendings are very involved too in the
Yep.
patients, but there's a lot of those interactions are now my responsibility. Um, because now I'm the provider. I'm
Yep.
not just, doing the tasks of nursing. I'm making decisions and I'm asking them to make decisions about their child. Especially when you get to end of life with palliative care, that kind of stuff. Like there's a lot of layers to what we
Yeah.
do in the ICU as a provider, and a lot of that is stuff that I end up taking on in my role as well.
So we're going to talk about that in the
Okay.
next episode. We're going to keep doing this. What I want to do is finish this episode with, if we can dig into the vault, tell me a positive story. Tell me something that ended unexpectedly positive for you, or that you took some of the most positive. It can still have a negative outcome, but be a positive story.
Oh, okay. So this is one of a more recent experience that I had. It was a child that was involved in a very bad motor vehicle accident, and they were going to die. And had we progressed to doing neurologic testing, they would have met criteria for brain death. And so we probably would have eventually have stopped any life sustaining care because they met criteria for death by neurologic criteria. The family
Yep.
was from Mexico, and they were some kind of an indigenous culture that had a lot of, like, very specific spiritual practices around death and dying,
Yep.
and they were very uncomfortable being in a medical setting. Um, I don't know, there's probably something very similar in Australia, but anytime a patient is going to die in the near future, we have to let Donor Alliance know. Donor Alliance is the organization that procures organs and helps with donation and finding matches for patients.
He, it's not the same, and
Yeah.
we can talk about that. We'll
Okay,
talk about that in
great.
the next episode because it's
Yeah.
a hugely important
So,
issue.
our protocol is to inform them that there is a patient that, especially if it's a patient who'll meet death by neurologic criteria, because then they can actually procure lungs, heart, liver, spleen, kidneys. I mean, they can take almost everything, and save a lot of lives in the
Yep.
process. And that is its own process, which I'm sure we'll get into. But they can be quite aggressive, especially when it's a patient who's going to be brain dead, because there is so much more that they can donate.
Yep.
Um, and we can go into the details of how that happens too later. But basically, this family wanted nothing to do with this process. Their spiritual
Okay.
beliefs,
Not understanding it,
their
or just
cultural
their
beliefs,
cultural
their spiritual
beliefs.
beliefs, it was wrong for them. And I tried to explain this to the Donor Alliance people, and they very pushy, and they sent their own representative in there. And I told the family that I wasn't going to abandon them. I wasn't going to leave them to have this conversation alone. That they had told me what they wanted for the death of their child, and it was I took it on almost as like a sacred duty to protect what they wanted that experience to look like. And I wasn't
Yep.
going to let anyone
Yep.
bully them or push them or convince them or coerce them to doing something they didn't want to do.
See,
Um,
advocating for the family and the patient is something that is woefully
oh yeah,
undervalued.
absolutely. And so that conversation happened. They, made promises that were not something they could actually deliver on, and I knew that, but they didn't know that. And there was a lot of things where they just stepped over the
Yeah.
line, and basically, I did what I felt I needed to do to just sort of kind of end this conversation and keep them in their place and really respect what the family had wanted. And so that was one of the big hurdles that we had to face. And then they were very ready to end life support, because they had known in their hearts that their child was gone. So they didn't want to pursue testing. They didn't need to go through that whole process, which is like a 2-day thing. Like, they were just ready, and they were ready that day, and they were ready with me. And so I was able to basically allow the death of their child to unfold the way they wanted it to. And this mother,
Yep.
we extubated her son, because the only thing keeping him alive was basically the ventilator and all the drips he was on to keep his blood pressure
Yep.
normal. We turned all those off. He passed away. It was like seconds. And she knew, and she got right in bed and she just
Yep.
held him. And this was like a almost teenage boy, but she just held him like a baby. She cradled him and she
Yep.
just wailed that gut wrenching wail that. But this time there was like a sense of, I felt like I did something really important for that family. I felt like I did something that honored their wishes and the
Yep.
way they wanted this experience to be. As horrible as the situation was, it was giving them something that was in alignment with what they saw would be what they wanted, and
Yep.
to allow them to have that experience without all the medical gear, without, you know, this whole process around procuring organs, like all the medical stuff that we do around it, and really make this as almost as natural of a death as possible, and to allow them to have
Yep.
that moment sort of unsullied, um, made me feel like I did right by them, and that I really honored them
Yeah.
and their child the best way that I possibly could. And so even though it was a very sad situation, I felt like I had done a really beautiful job in preserving that.
You made a
Yeah,
difference in somebody's
yeah,
worst time that would have been
yeah,
so much worse if you
yeah.
didn't do what you did. Yeah. All right. That's beautiful. Mate, thank you. We're going to end this episode and then everyone come back and there'll be more with Adam on the next episode. Thanks everyone for joining in. Make sure you let us know if you've got any questions and we will see you next time. Thanks for listening to this episode of Beyond the Call. If you like what we're about, please make sure you subscribe, and if you can leave a review, that would be appreciated. If you have feedback or suggestions for future guests, please contact me via my socials. Please share with your networks and help me expand my reach. It's a great privilege for people to share their stories and allow us to go beyond the call.